Yes. Good afternoon. Welcome to the 11th webinar. Today it's titled Continuing Health Services During an Outbreak. I am Dr. Lynn Tjirare-Ookame. I'm employed by the Ministry of Health and Wellness, currently in the Public Health Master's Program at the University of Botswana. These webinars are aimed to capacitate and to update us as healthcare workers on COVID issues in Botswana. They are co-organized by the Ministry of Health and Wellness, the University of Botswana, Botswana-Harvard Partnership, the University of Rutgers University. So if you'd like to continue joining us and having invites, please do email robert@rmumakwa@yahoo.com. And please do mute your mics. Use the chat functions to post any questions that you have. We have a moderator who will be looking at your questions and the presenters will answer them at the end or during their presentations. The sessions are recorded and will be availed. And please do take time to fill in the feedback surveys. It's very important so that we know what times are appropriate for you guys and what topics you would like to continue hearing. With that said, I'm privileged today to introduce Dr. Josephine Namboze. She is the World Health Organization representative in Botswana since the 1st of August, 2019. She has previously held the same position in Eritrea. She has been in the World Health Organization for over 24 years, so she is vastly experienced. She is a leader and a public health specialist with exceptional experience in health system strengthening, disease control and prevention, the humanitarian preparedness, emergency preparedness. So she is the right candidate today for us to share her wealth of knowledge and to have a very fruitful discussions on continuing of health services during an outbreak. With that said, Dr. Namboze, the floor is yours. Thank you.
Thank you very much. And I don't know who is supposed to just go through this.
She has already done. You can go into your presentation, Doc.
Okay. Okay. Thank you so much. And I would like to thank you for the opportunity to talk about an area that has basically not received adequate attention, not only in this country, but throughout the region. One of the things we are experiencing, especially when we suffer an outbreak, is that if this particular component is not adequately addressed, the challenge would be that you get a lot more deaths due to ongoing conditions rather than the outbreak. And that's why it becomes key. So not surprising that during the COVID-19 outbreak, this area has already seen a lot of challenges. And the health systems are overwhelmed both directly and indirectly by mortality increases, mainly from different reasons. And I think later on we'll try to look at that. And this is extracted from lessons from the 2014-2015 Ebola outbreak, which showed an increased number of mainly the indirect deaths, which were far more than the ones that had been due to Ebola. And therefore, it brings in the basic response where the system, to look at the system's ability to maintain delivery of essential health services, depending on how bad the outbreak is. In the context of COVID-19, we have made 4 classifications: no cases or sporadic cases, clusters, or community transmission. Depending on where the country is situated, we have a package of services which we recommend. And for Botswana, the cases have mainly been sporadic and in clusters. So basically that is the kind of classification that we would go for when we are looking at the different districts. And then maintaining the population trust with the health system so that they can safely meet the essential needs becomes key. And one of the key things is that if you lose the trust of the population, they will not use the health services, and therefore you complicate a lot of the other conditions. And a well-organized and prepared health system would basically have the capacity to maintain equitable access to service delivery throughout an emergency with reduced consequences. And if we attain that, we would then say the health system is resilient, so that no matter what happens, it doesn't matter whether we get another outbreak, it will be able to cope. So with limited COVID-19 caseload, health systems have the capacity to maintain routine services as well as managing the COVID-19. But when caseloads are high, and when the health workforce, due to different reasons, are not adequate to deliver both functions, then we basically recommend strategic shifts for maximum benefit for the population. Districts in Botswana will need to balance the demands of responding directly to COVID-19 with simultaneous planning and coordinated action for essential health service delivery. Many routine and elective services may be postponed or suspended depending on the context, especially if we have very high cases. But as of now, with the current situation, perhaps there is no need to suspend routine and elective services. But basically, we have to design the proper governance mechanisms and protocols and establish effective patient flows, especially in all the health facilities, to make sure that there is adequate screening, there is triage, and there is targeted referral for COVID and for COVID cases and non-COVID cases, which should be done at all levels of our healthcare. Can I pause to find out whether you hear me properly and you can see the presentation okay? Hello?
Yes, we can. We can hear you and we can see the slides.
Okay, let me continue. So for the aspect of continuity of health services and resilient health systems, because as much as possible, this is what we are looking at. I want to draw your attention to this illustration of a spring row pre-crisis, during a crisis, and post-crisis. And basically what we want to demonstrate to all of you, pre-crisis is basically the normal health system. Everything is functioning optimally. However, once there is a crisis, the health system usually is not functioning optimally, because in addition, it has to include a lot of other epidemic preparedness and response activities. And therefore, usually with the same people that have been delivering the pre-crisis interventions. It's the same people that have to deliver the crisis. So finally, the health system will get compromised during the crisis. But then the intention is that post-crisis, we would then extend the services so that the system is better prepared. And that's what we are talking about, the emergency preparedness and response. You establish all the required capacities to be able to respond. At the same time, you also look at the health system so that it is completely resilient, so that in future, you wouldn't get the problem. So basically, this is all the illustration that the results will be much more post-crisis compared to the pre-crisis period. Now, when we are looking at the continuity of services, our recommendation is first and foremost to basically get the information whether your services are affected or not affected. And we have kind of classified this into 3 major steps to make sure that we look at it constructively. The first step is actually the monitoring of disruption of essential health services. You would look at, and the major aim under that is to monitor the disruption of the services in every district, in every region, and at national level. And then you support with advocacy and do the relevant coordinated actions. The methodology can both be qualitative with anecdotal reports, or quantitative, where you basically look at the routine response and you look at the indicators, you look at the C-trips that are being produced. And for that, we actually also recommend that the C-trips after the initial crisis should also look at the best way to include basic indicators for continuity of health services, so that we don't lose a lot more people due to that. The second step is containment, is basically looking at the causal analysis. And in this, we look at the different factors, and these factors have been grouped from what we have learned from the different countries within the region. One of the first one is the containment measures, especially the lockdown with restrictions of travel and access to referral services. This has greatly affected our interventions, and we need to assess how much that has contributed. Then usually the repurposing of resources. This could be health facilities, human or other resources. Usually the human resource, especially in the context of Botswana, is the one that has affected most of the the continuity of services, because human resource has been repurposed for to focus more on the COVID, and somehow there was a gap on the continuity of services. Then the other is the fear of contracting COVID at the health facilities, which limits access to the facilities. Sometimes the actual absence of health workers who fear to get contaminated, especially when the PPEs are not adequate. Challenges in procurement and distribution of essential medicines has also been noted. And then the negative rumors, especially when you start immunization during a crisis, it can be perceived that you are forcefully giving people COVID vaccination, depending on the context you are in. Some may want it, others may not, and sometimes that causes a lot of challenges. And then the financial constraints, transport, and so on. And I think in our context, because most of our routine budgets have been diverted to manage this crisis, this has contributed to some of the issues related to continuity of services. The third stage is then the implementation. And on this one, we felt that maybe it would be worthwhile to share some very good practices that we have experienced in different countries. And related to that, I can do something. Related to that, for coordination of response to disruption, we have very good examples from Namibia and Uganda, where they have established a subcommittee at the National Task Force itself for continuity of essential health services. And they routinely report on the key indicators. For monitoring and quantification of disruption, we have an example in Rwanda where they've established a national hotline for flagging any issue associated with service disruptions. And then from Uganda, Zimbabwe, Kenya, and Namibia, they've established mechanisms for monitoring disruptions of health services by routinely reviewing HMIS data. Then management of risk perceptions amongst health workers. In the COVID-19 treatment centers linked to, but separate from the main hospital and health facilities in Rwanda. What they have done is that to allay the anxiety and perceptions of the health workers, they have established completely separate wards for COVID patients, so that the population is more confident to go in the usual facility and not knowing that the COVID patients are being scanned and screened for management elsewhere. The other one on managing risk and perceptions amongst communities, it is an intervention that South Africa, Zimbabwe, and Rwanda, and actually Botswana has implemented in provision of medicines, which are refills for a longer period of about 3 to 6 months, so that those with chronic conditions, unless there is something really severe, they don't have to come to the facility. And then travel permits were issued for pregnant women to attend antenatal care, and people with chronic care allowed to travel and seek care when needed during the lockdown. And that's an experience from Uganda. coordination. The next set of slides really go into some of the small things that you could put in place to ensure continuity of services. And one is the coordination that basically looks at the purpose, design, governance, and coordination mechanisms. And all that basically talks to having simplified mechanisms and protocols that will inform you as you basically go around. I won't perhaps go into the details of each and every one of these slides, and basically to ensure that you are constantly monitoring the usage of your facilities. The other one is to optimize service delivery platforms, which talks to making sure you map out the facilities and what they are able to provide, and basically make sure that things where there is need for repurposing, that is done, so that for all, especially for the very severe cases, they have a place where to go, and you establish the relevant outreach mechanisms and adequately prepare your health workers to look at that. And then the effective patient flow in terms of screening, triage, and targeted referral. This is key because it is the one that will let the communities know whether your services are adequate for them and whether you are basically taking care of their safety. And that is something that needs to be looked at and adequately addressed to ensure acuity based triage for acute care that is being delivered, which basically means that when people are coming to the facilities, they know exactly those with acute respiratory infections of pneumonia, influenzas, they are kind of singled out to take another track and go to the relevant service area. And the rest who have other conditions also go to another service area. The other one, which is important, is the redistribution of health workforce and reassignment and task sharing within the facilities. Earlier on, it is important to map the human resource that you actually have, and then make sure that you put in triggers during the whole setup of response to outbreak, so that once you reach a certain level of cases, then you will have to repurpose health workers, with some of them remaining on the continuity of services, but the other looking at the COVID specific requirements. And then of course, there is the whole issue of availability of essential medications, equipment, and supplies, which must always be paramount, because a lot of focus sometimes goes to the COVID specific issue, even among the COVID patients, so that what happens is that basically you neglect the other conditions they may have come with. And I think that is one of the things where we have lost so many patients, because they look at the COVID and then sometimes forget the diabetes and the hypertension. So all that needs to be put together and worked on comprehensively. So the success factors, if this is carried out properly, mainly they would require these strategic shifts, transparency and frequent communication with the public, which is key. They need to know what you're doing and how you are addressing all their fears. active engagement of communities and other stakeholders, and specific protections to ensure access to socially vulnerable populations and a high degree of cooperation from individuals. So basically, I've just given you major highlights on the issues related to what normally affects the continuity of health services and why we should basically care about that, and usually how the system itself is affected. And I ended up with some few slides on some of the things that we can concretely do to address these challenges. So I think I know I had to stick to 30 minutes, and that's why I rushed the last slide so that I'm within the time. So I think that ends my presentation. Thank you very much.
Thank you, Dr. Namboze, for the informative and brief presentation. You mentioned a lot of important aspects relating to continuing services while amidst an outbreak. And I'm sure we have some of our participants who would like to perhaps ask or have a discussion over what we have just heard today. I don't know if you had the questions from prior to the presentation. Would you like to address those before they pose their questions?
Is it the ones in the chat box?
Yes, those are the ones.
Okay. Thank you, Charles, for the question on the shortage of blood in our country during the COVID times. I may not know specifically some of the issues because some things are specific for Ministry of Health. But what I do know for sure is that they have established linkages with the blood bank to be able to monitor what is going to, the blood supply that they have at hand, so that we basically come up with interventions to be able to address if the supplies go to a very low level. But as far as I know, the exercise hadn't started from the national level, but it is one of the key indicators they have defined and that they would need to feed back on a weekly basis. So I think I don't have a clear answer to that question, but maybe somebody else within Ministry of Health could help with that.
Thank you, Dr. Namboze.
Okay, on the second, which is the ministry collecting data on how the lockdowns may have impacted service delivery, such as SRH, HIV, and TB. Thank you, Lucy, for that. Yes, the Ministry of Health has come up with a situation analysis looking at the last 4 months, how the indicators in those key programs have been affected. And indeed, especially SRH, HIV, and TB, those particular programs have been badly affected because for most of the indicators, they have gone down. And based on that, they are trying to look at different strategies that would help improve the coverage on the indicators. I think that's it. Those are the two questions I see in the chat box.
Thank you. Colleagues, do we have anybody who wants to pose a question? Okay, it seems we don't have questions today.
Mm-hmm.
Thank you.
Maybe it goes to saying that because it's an area that has not been adequately addressed, and that's why even the level of interest is not that much compared to the COVID specific areas. But we felt that this, because of the neglect to this aspect, we needed to look at it. One of the things which I kind of forgot to mention, but which may be useful, is that Botswana as well has done a risk assessment of all the districts to basically see how exposed they are to COVID-19. And if they are exposed, their level of readiness to be able to mount the appropriate response. So in line with that, we have categorized the districts into very high risk, high and medium and low risk. So the basic information is that for districts that are very high risk of COVID, they would just have a basic package that they implement, especially for the maternal and child health, the services that don't need a lot of work. But then for the low risk, I think the districts would need to implement the total package. And there is another question, is Botswana implementing the differentiated service delivery model? As of now, I'm not so sure, but I don't think so. I think it is something that is planned and will be implemented in the course of next month. Thank you, and over to you.
Thank you, Dr. Namboze. Out of interest, just generally, not in Botswana, would you say we have a number of countries that have depicted having health system resilience? Are they countries that are standing out amidst the COVID response?
Okay. It's a difficult question to answer because what we have done in the region is to basically grade health systems resilient. It has about 4 or 5 stages. So we actually have countries that are perhaps the first 2 and 3 stages, but not the complete. So the intention is that for those countries, we'll be able to get them to the final, and then the ones that are still at extremely low health service resilience is to work them to what is acceptable. And I think the country that quickly comes to mind is Rwanda. It is at a fairly advanced health systems resilience, and somewhere in between, Zimbabwe actually is somewhere in between, looking at some of the markers. And then, of course, countries like South Sudan is perhaps on the lowest end because of the complexities in that environment. Therefore, Botswana would fall on a level 2, a level 3 in there. And if we are able to build the systems, I think during this time and after, we'll get the health systems resilience. Thanks, over to you.
Thank you very much, Dr. Namboze. It was quite an interesting topic. And like you said, because it's not quite COVID response related in terms of the topics that we usually discuss, maybe that's why we have not as much questions as we would like. But it was quite informative. I think in the public health space, it's really, really relevant even in these times. So with that said, with no more questions, I would like to thank our participants for joining today. And please do remember to fill the feedback survey and be on the lookout for our next presentation. Thank you very much.
And thank you, moderator, and all those who participated. Thank you.
Thank you.
Thanks so much.